Welcome to another episode of Clear Lake Connections, where we talk to the people behind the businesses of Bay Area Houston, proudly sponsored by UTMB Health. Today's special guest is Dr. Saleem, and you are an Associate Professor of Radiology at UTMB in Galveston. Is that correct?
Yes, sir, I am.
Okay. Tell us about, first of all, what is radiology?
Well, radiology is basically a field of medicine where we are utilizing imaging to diagnose and direct medical care for patients for a lot of different pathologies. A lot of our patients are coming from general surgery, from all different subspecialties of medicine. So basically, you can think of us in present day and age as the air traffic controllers of the field of medicine. We are the backbone of any hospital system and the entire medical system in any place. Nowadays, any patient who is going to be coming into hospital system is going to be getting any kind of imaging for sure. You take ER, you take admitted patients, you take patients who are coming through the clinics. Any and all patients are going to get at least one exam ordered by the physician who's taking care of this patient. And those exams are going to determine what's the course of the action which is going to be taken by this medical team, surgical team, or the physician who's taking care of them in medicine, in clinics, or in ERs. And these medical modalities include ultrasounds, X-rays, MRIs, and even CT scans and some procedures as well. And without those imaging modalities or knowledge, a lot of it cannot be achieved what we are able to achieve these days in all the subspecialties, from head to toe. Any and all parts of bodies are being imaged, and we get the results, and we move forward from there. So that's radiology.
Okay. So technology has kind of ramped up over the last, it's just kids faster and faster. What are some of the major changes you've seen in the field?
Oh, wow. Yeah, that's a very, very good question, because I'll just tell you, in last 10 years of me being in the field of medicine, including my training and up until now, and when I was in medical school, back when I was in medical school, and I remember at that time, most of us used to think of radiology, this is just an X-ray department. You just do an X-ray and that's about it. Maybe just an ultrasound or two. Not much was even known within the medical school even about the field of radiology itself, what subspecialty or specialty it is. And things have moved forward so fast that it's so difficult to even kind of know what's about to happen the very next week. I'll give you an example. When I was a first-year medical student, a CT scan that was done, first and foremost, not every patient was getting CT scans. Why? Because CT scan was considered a big exam that was going to be done. It's involved a big machine, and it takes this much amount of time. And it would take about 10 to 15 minutes to completely image a portion of the body of a patient. Nowadays, just within the span of 15 years, I should say, the same scan is done within 3 seconds to 10 seconds from head to toe in the same CT scanner. So things have advanced far more than we could have imagined back then, and they're growing at a pace that one just can't wrap their head around them.
Yeah, I guess for me, it had been a long time, I guess, since I'd had an X-ray, and I had my hip replaced recently, and they said, "Oh, you're going to go get an X-ray," and in my old head, I'm thinking, "Oh, yeah, it's going to take forever, and they're going to have to print out the X-rays." I go back to the back to the exam room, and he comes and pulls it up on the computer, and there's my X-ray in a minute, and I'm just like, "Wow, yeah, we have come a long way."
Absolutely. And I've seen those days when even the CT scans were being read on X-ray films. There were little tiny squares, and the radiologist would be holding magnifying glasses, going one slice to the next slice to the next slice. Right now, it's all on computer, and it's just like a game. It's you're scrolling through the entire patient's body within seconds, and you're changing the views and everything, and you get to know what's going on. And
so, how did you get into radiology? What about it struck a chord?
Well, So from the get-go, when I went to medical school, from the day one, the only specialty or only part of medical um, teaching which really struck to me and made me feel like I was becoming a doctor was anatomy. It made me feel like I'm doing something which is far beyond what I've already been doing. Any other specialty or any other subject of medicine would just, to me, kind of like feel like it's an extension of what I've already been reading and studying before, biology, biochemistry, stuff like that. And I knew from that point onwards that whatever I'm going to be doing is going to be very deeply integrated into anatomy. And I thought I was going to be a surgeon. That I'll be able to appreciate human anatomy by being a surgeon, dealing with different portions of the body, organs of the body. And the other portion that kind of played a big role into me becoming what I am today was I wanted to, and a lot of it has to do for each doctor or physician. It has to do the type of personality they will have particular kind of affinity for a particular specialty too. So someone like me, I want to know very quickly what's going on, what's wrong, and if I can fix it, and I want it seen fixed and working fine. So I knew I was going to be a surgeon, truth be told. So I liked anatomy. I wanted to fix things. I wanted to see them fixed and working fine quickly. So I was all right. I'll become a surgeon, and that's what I thought. I went through the medical school. Towards the end of my medical school, I got exposed to radiology through surgical rotations. We would walk down the ER hallway to the radiologist room after every trauma patient was coming through the ER, and we'll see what's happening with the patient from inside out. And I would look at these CT scans and the way they were looking at them. I was like, wait a minute. I feel like I can appreciate anatomy and be intricately involved with it way more as a radiologist than I can be as a surgeon, because these days surgeons are so super specialized. Some of them are just the surgeons of vessels. Some of them are just the surgeons of liver, just the bowel, just brain, different portions of the body. Whereas in radiology, I can actually appreciate the anatomy from head to toe any given day. As a radiologist, I'm looking at X-rays and CTs and MRIs and ultrasounds of head, eye, brain, chest, liver, heart, and everything.
So you're basically finding the problem that the surgeon then can fix.
Exactly. And then there was variety to it too. It wasn't just monotonous. So I was like, all right, this is something which something which I really like. And it was different than what I was thinking I was going to do. But there was still one portion which was really bothering me. It was like, would I be able to do something about it, or just let them know there's a problem? And that's where interventional radiology came into the picture. And this is a subspecialty of radiology further after you've become a radiologist, where you do procedures under image guidance. So using X-rays, ultrasounds, CTs, and MRIs to do the procedures and fix problems in the body, which back in the day were only be able to be done by cutting the patient open and doing in that particular way. Mm-hmm. By using radiology, the other thing I noticed was I don't have to really cut people open, make big gashes, and achieve the same goal, whereas I can just make a small, tiny puncture wound, do the same thing, just because now I can see through the human body utilizing X-rays, maybe MRIs and ultrasounds and CT scans. So that was really, really...
So you almost got the surgery part that you wanted in the beginning.
Exactly. Yeah. And also it was a way more advanced way of doing things and a way more cooler way of doing things. And last but not the least, interventional radiology to date kind of gives you the opportunity of doing procedures in any part of the body from head to toe, not just one particular portion only, which I saw was the case with surgical specialties, and it's the need of the time also that you are more super specialized to do particular kinds of surgeries only. Yeah. So it kind of solved all three of my issues. I'm gonna be appreciating anatomy, enjoying it. I'll be seeing what's going on with my patient, diagnosing it really quickly, and I'll be fixing it myself too in a more comprehensive way with less monotony and a lot of variety.
Yeah.
So that's how I got into radiology, and particularly interventional radiology.
And so how did you get to UTMB?
UTMB, well, it's so after medical school or during medical school, all of the medical students, they have to go through a process of matching process to where they're going to be finally doing their residency training. And during this process, you apply all across the country. And when I was applying for my match process, only 5 programs in the entire country were at the time offering this particular subspecialty being offered straight out of medical school. You see, interventional radiology up until 2015 to 2016 was only a subspecialty you could only do after you've finished radiology, basic radiology residency training. And then they thought, well, it's becoming more specialized and becoming more prevalent, and we need more of them, and it's becoming more mainstream. So they started offering this training straight out of medical school as a comprehensive training track. And my year was the first year when they were actually rolling it out as a what should I say, experimental way too. So 5 different programs were doing this training 5 different ways just to see how it goes, and then they can adopt one particular way. And UTMB was one of those. So I said, well, let me just apply here too. So I applied here, and believe you me, I interviewed at 38 different places in the United States. And back in the day, we were supposed to travel physically. Nowadays, everybody's doing online interviews since COVID. We used to go in person and experience the city, the program, and everywhere. And most of my interviews, because I was in Cleveland Clinic School of Medicine, were all up in the north and the East Coast. And I got one interview in Texas, and it was something which was very interesting for me. So when I came, I still remember when
Texas can be interesting to people from the north.
Oh, absolutely it was. And I remember it was November the 7th, 2014. I landed at Hobby Airport. And once I came out of the aircraft and out of the airport, there was this warm, humid air. And I was actually, through all my interviews, I was wearing these heavy, long coat, jackets, and all the warm clothes were with me. And that's what I was thinking. Maybe I'll face the same thing here, but that wasn't the case. And we went down the Broadway on Galveston, again, a beautiful drive, palm trees, and I'm seeing people in tank tops and shorts and on their cruiser bikes in flip-flops. I was like, this is amazing. And right before UTMB, you take a turn right at the seawall, and that was it. I was like, this is amazing. This is beautiful, especially for someone who's been traveling through snow throughout the match season. It was amazing. So
what I've noticed about the culture at UTMB is they let you kind of explore and take programs and kind of grow them.
Absolutely.
Have you experienced that as well?
Oh man, I think UTMB, if you were to ask me would I do the same thing again now, I would say absolutely, I'll do it over and over again. UTMB is a place. This is what I tell my colleagues, this is what I tell my juniors, this is what I tell all the other folks in the Society of Interventional Radiology and radiology in general, is that this place has provided me with a platform where not only was I able to grow myself, but I was able to grow and build and develop the department and technologies and educational programs as well. It was an amazing experience, and I don't think I would have gotten the same experience at other places, may even be bigger institutions in the United States. And people were like, well, hold on. You can't just say it like that. Well, here's the thing. I've trained at Cleveland Clinic. I've trained at other bigger institutions as a medical student too. And I know the cultures now after going through training and talking to other folks. In other big, very well set, bouldered institutions, there are big personalities. There are big processes and bureaucracy there, which kind of has its own roadblocks of developing programs, developing departments, and all. Whereas at UTMB, what I saw, not only the culture, but also the way it is structured, it was amazing. I was not only supported by my seniors and the system itself, but in general, by the size of the institution, its history, and also its methodology, should I say. It always provided me with the perfect platform to come up with my ideas, institute them, and then develop them. As a resident, as a faculty, I'm a very young faculty. I've been able to develop a whole department of interventional radiology from only 2 intervention radiologists to 8 of us now, and we're growing. Our goal eventually is going to be 12 of us. By next 2 years, we will be 12.
You've got to do that just to keep up with the growth of the hospital
exactly
system.
And
you
also
guys are everywhere now.
Exactly. We are from Angleton to League City to Clear Lake to main campus, and it's even growing more. And not only that, the different kinds of treatment options and solutions with precision medicine that we can offer is just growing rapidly. We're going out there today. I'm here. We're talking to you guys, and that's again part and parcel of my growth. Is I want to make people aware of what we can offer, and once people start to getting to know what this specialty can do for them, there you go. Boom! It's like it gets like really busy really quickly. Our training programs, I was able to take it just from a super tiny specialty fellowship, which had to happen after 4 years. Now we have 18 trainees, where we used to have only 1 trainee. We have 18 trainees. In the last 5 to 6 years, we've grown that much. We have 3 different tracks of interventional radiology training that can be offered, and all in one umbrella. In Greater Houston area, this is the only place where you have all 3 different super specialized tracks for this cutting edge technologically advanced specialty. And it was only possible because of the medium I was provided here at UTMB. Not at UT Houston, not at MD Anderson, not Methodist. It's the biggest medical center in the world. None of those places have all of them 3 in one umbrella. Only here at UTMB.
Yeah, I don't think people realize that little hospital in Galveston is probably one of the most progressive organizations there is, and allows people such as yourself to kind of explore and create these programs.
It's a hidden gem in this day and age, and I would say it's a great place. Big names have come out of that place. Big names who have developed institutions all across the United States and the world actually came out of UTMB itself as well. Mind you, this is the first ever medical school of the state of Texas and south of River of Mississippi. So it has history, and it has culture, and it has produced some big names. And to date, it carries its culture of continuing to do so.
Yeah. And so do you still teach?
I still teach.
Okay.
I'm the residency program director for the interventional radiology residency programs for all 3 different tracks that we have. And I do actively teach the medical students. And I'm a course director for 2 different courses at UTMB as well for medical students.
Okay.
And it's something which not only I enjoy, but a lot of my other faculty enjoy as well.
And you get to try to recruit the next generation of
absolutely
radiologists.
Absolutely.
So you had stated that interventional radiology can now, it goes beyond just seeing, but you can actually take care of the procedure. What are some of the more common procedures that you can take care of, as opposed to having a surgeon go in and, like you said, cut open and do more damage?
Absolutely. So when it comes to interventional radiology, and before I go into the depths of that too, or talk about a few conditions that we can treat and offer to our patient population, I really want to know, and just I'll ask you a question, and we can take it from there. what comes to mind when I say interventional radiology? Or let's just say you hear it in general masses, talking with friends. Hey, there's a specialty called interventional radiology. This person is an interventional radiologist. What comes to mind? Does it
Yeah, it
really?
wouldn't. It doesn't really. I guess you can work through the words, and I guess come to the point. But I think maybe
We
intervention, obviously, and then radiology. But I wouldn't
Yeah,
have put the two
and when I
together.
say cardiologist, what comes to mind is
The heart.
right. When I say gastroenterologist,
Yeah, the guts.
OB-GYN, or like
Yeah,
obstetrician,
it's
pediatrician,
the more well
surgeon,
known, right?
neurosurgeon. Like
Yeah.
these are well known, and you will exactly quickly relate to it, and you can talk to, or you can reach out to that office, like, hey, I got a problem for such and such. I'm just gonna go to a hepatologist or a gynecologist or something like that. But for interventional radiology, since we are very new, and our name is kind of like a little confusing too for general masses, what we've done, at least at UTMB, and we're working on it too, and we have realized it, is if I go and shake my hands in the morning with my first patient, hey, Mr. Jameson, I'm Dr. Saleem. I'm your interventional radiologist for the day. By the time my sentence is ending, the patient is cross-eyed and they just don't know. They're like, all right, my doctor is actually the doctor who sent me to this guy. This guy is just going to do a test and I'll be out of here. My doctor is still that doctor. However, if I met with my first patient and you were my first patient, say, good morning, Mr. Jameson, I'm Dr. Saleem. I'm your image-guided surgeon and my team is here to do a procedure for you. You will immediately relate to me and you would kind of identify me as someone who's going to do something important for me.
Yeah.
Exactly, right? So interventional radiology, at least at UTMB, we're rebranding it and we're putting the name of the Department of Image Guided Surgery for it, and so that our patients can also really completely understand what we are doing. And truth be told, sometimes even in the field of medicine, some of our referring providers may not completely know exactly the complete breadth of things that we can offer. And a lot of it has to do with the fact that we are something which is very new. And again, we are still considered under the umbrella of radiology, where we just sit down in the dark rooms and just study and read X-rays and ultrasound like vampires. We never come out of our dark rooms. No, we this brand does come out, and we do go and we admit our own patients. We see them in clinics. We do procedures on them, and we see them in the ER. We're outside of the dark rooms. We sometimes go and hibernate there for some time. So talking about interventional radiology, or so to speak, image-guided surgery, there's a lot of things that we are offering to our patients. We are, so to speak, the new generation of generalists or general physicians, so to speak, who can offer procedures too. And we do offer a lot of different solutions to our patients from head to toe. You can put your finger at any part of your body and I'll give you 5 different procedures or solutions to the problems that we can offer as a specialty to you. Now, that is not common knowledge, and that's our biggest effort these days as the specialty is growing, is to bring that to common knowledge and let the general masses know about that too, so that they can ask about those solutions from their general physicians, from their PCPs, or even sometimes go directly to us as a specialty, like someone would go to a dermatologist for a skin problem. And speaking of that, there's a lot of things that come to mind when we're talking about image-guided surgery. Is there are a lot of issues and problems which were in the field of medicine present to date, which may not have a good solution, may not have had a good solution, just because the patients were just not good surgical candidates. We as a specialty are actually bridging a lot of gaps as well in the medicine in general. So there are a lot of patients who may not, just because they have weak heart, they have some other issues going on, they have to be on blood thinners, they cannot come off blood thinners for other medical conditions. They just because of that, they cannot have a major surgery. Well, guess what? You can come to us, we can achieve the same thing without having you go through a big surgery where big cuts have to happen. And we are also the ones which, any part of the body, if you're bleeding from, and even if surgeons have given up, they send them to us, because we're also very heavily involved in having the patients stop bleeding from any part of the body. So we are bridging a lot of gaps in different issues, medical issues, which we thought we didn't have any solutions for. And to give a few examples, we also treat a lot of older gentlemen have prostate issues. And by that I mean, as a gentleman is getting older, you can have the prostate slowly and steadily start growing bigger, and you can start having issues where you have to go to the restroom quite frequently, and you can't sometimes control urination urge. And for those individuals, historically, they were going to urologists. Our urologic colleagues are doing a great job actually treating this issue, and a lot of times they have to go through surgical procedures to get this treated. And once the medicines have given up and they can't be treated anymore with the medicine, there come a point where they have to eventually go through a surgery. And truth be told, not every patient may be a good surgical candidate. Even for the urologist, they may tell the patient, hey, listen, this is the answer, but you may not be a good surgical candidate. Or the patient themselves just don't want a surgery done to their prostate. They're just afraid of the surgery. Well, we can come in and we can offer a procedure. We can just go in very minimally invasively with just tiny puncture wound in one of the vessels, and then block the tiny small arteries which are supplying the prostate to help it shrink. So you didn't have to go through a major surgery. You don't have any bleeding issues. If you were afraid of a surgery, that's okay. You can come to us and we'll take care of it. And you walk out the same day. You get the procedure done. Within 3 hours, you're walking out of the door and you go home. So there is no post-surgical bed rest or days lost to work if you were working, or any restrictions. It's a normal day procedure and safe procedure. Out you go.
Yeah, I think that the huge selling point there is minimally invasive.
Absolutely.
I mean, just one tiny that's
Absolutely.
and you can do that for other procedures as well.
A lot of other parts of the body, a lot of other procedures. Another example that comes to mind is you get a CT scan, and you incidentally get to find a small cancer in your kidney. Okay. Historically, what used to happen was they'll watch it. Once it starts growing, they'll start going in and try to take the kidney portion out. But the issues that come along with that is when you take a portion of the kidney out, it actually reduces your kidney function. It's a major surgery. It has its own issues with anesthesia, this, that, and the other. Whereas these days, you can have a CT scan done. You found a renal cancer, which a mass which looks like a renal cancer. They usually send them to us just to find out what kind of cancer it is. What we are started to do in collaboration with our urologic colleagues and other surgeons, that if it's a small cancer, not only do we biopsy, we right there and then just freeze it off with the same needle which is inside the tissue with tiny needle, tiny needle. You freeze the cancer, patient walks out knowing what kind of cancer it was and also cancer free. So within 1 day or a couple of hours, you're cancer free. You don't have to go through a big surgery, or you don't have to go through big chemotherapies and whatnot. So
this sounds like one of those best kept secrets that we need to get the word out. Like maybe an entire list of, if I go to a doctor and they say you need this, I'm like, this guy can do it without the trauma.
Absolutely. And we can talk about one more thing actually. A lot of our patient population, especially here in Texas, it's a major issue that we have, being overweight, right? And as you age, your joints of the body are aging as well. And now if we have the issue of obesity, of being overweight, or in past you were having a job such as you were in military, for example, where you were carrying heavy weaponry and you were going out in the field and your knees were hit pretty bad, you can start having issues such as osteoarthritis. In the past, the treatment options which were available for these folks was to be on pain medications first. And if it doesn't work, they're going to go through a major surgery where their knees will be replaced. And truth be told, any surgeon would tell you the knee replacement surgeries usually work for no more than 10 years. You know, you have to have something done after 10 years. And it's a major surgery, right? So they will try to push it out with pain medications as much as possible. But what's the pain medication doing? It's actually burning out your kidneys and your stomach. You start having stomach ulcers or kidney issues, kidney problems. By the time you're on the table for surgery, you may be nearing a renal failure, God forbid. Well, what can we do now from the image-guided surgery standpoint? We can actually come in, and the procedure we just talked about, the prostate embolization, we can do such procedure for small vessels which are causing inflammation and pain in the knee with a small, tiny puncture wound, go in with a hair-thin, tiny catheter and block those arteries without any damage being done. The pain goes away, the inflammation goes away, the progression of damage goes away, you're off the pain medications, your ongoing progression of damage is gone, so your possible surgery, which was going to be happening, say, 5 years from now, may be actually happening 10, 15, maybe 20 years from now.
Yeah.
You know, and you may actually do good amount of physical therapy because of absence of pain and not need a surgery, you know.
Yeah.
And walk out the same day. So, minimally
Yeah, I'm going to
invasive.
need that list.
Absolutely,
I'm
absolutely.
going to need that list. That's...
And it's on and on and on. Like I mentioned, you can put your finger at any part of the body, and I'll give you 5 to 10 different things we can offer to you.
Yeah.
And what we're talking about right now, we're doing the same with our other medical colleagues as well, because with the advancements which are happening in our specialty, they're just so fast that even for us, sometimes it's something new, and we're like, hey, we can offer that. Let me go and talk to my orthopedic surgeon. Tell him, like, hey, your patients who you think cannot get surgery or you don't want to do surgery on them just now, send them to us. Let us deal with their issues. And we're trying to go to all different specialties. Believe me, even dermatologists we're going to, because there are certain things we can offer to dermatology patients as well. So, yeah.
So it sounds to me like you're in the most exciting, probably field of medicine right now there is. I mean,
absolutely. And one more exciting part I will leave you guys with is UTMB, again, is the only place in at least in the United States, where NASA is actually having their training program where the physician astronauts are being trained to go and be in the space missions with NASA, SpaceX, Amazon, all of them. And we're working very closely with them because we at UTMB have proposed as an institution that if there is going to be a physician in future who can actually go on a long-term mission, say to Mars or something like that, the best physician to send to space is going to be an image-guided surgeon or interventional radiologist. And the reason being, not only can we treat medically and manage patients medically, but we can also do surgeries and procedures with equipment which is very minimal, lightweight, and you don't have to carry all those surgical trays and everything. And with just a simple pocket ultrasound, we can take care of so many different emergencies which in the past you used to go through big surgeries. So we are the solution you need to send with your astronauts to the space, and we are actually working on it. We have written about it, we got published about it too, and hopefully we will be able to get more traction, maybe get involved with the industry and send our folks there too.
Very exciting.
Exactly. So there are a lot of different areas we're expanding to.
That's excellent.
Yeah.
Yeah, you guys have a big job ahead, getting the word out.
Yeah, for sure.
And here I'm like a sucker getting cut.
I know, getting your hip replaced. He could have taken care of you.
No, I saw the x-ray. There was no taking care of that. It was bad.
Yeah.
And the thing is, we actually come into the picture even before it becomes that bad. We take care of things right there and then. Yep.
Well, I guess the first time I had it done, if it would have been an interventional radiologist, maybe there would have been something that could have been done to at least slow the progress.
Absolutely. And maybe actually to complete kind of like pause and resolution of acute symptoms, so you don't have to go to that. For female reproductive issues, there's big drive towards that too. A lot of females from certain ethnicities have big issues of fibroids, heavy menses, pain, miserable life, pelvic pain, congestion syndromes, this, that. In the past and to date, most of them, whether they want the uterus out or not, eventually will have the uterus out. And some of them may want to keep the uterus and not want to go through a big surgery with a big cut to the belly, and for many reasons, for different reasons. Nowadays, we can go in and we can do the same embolization procedure, and those fibroids, they can be 10 centimeter long to whatever centimeter long, they shrivel down, and then they get to stay away from a big surgery. The bleeding symptoms go away, and same goes for pelvic congestion syndrome too.
Wow.
We can just take those painful things away from them. And there used to be a concern about fertility, but that's also, in the recent literature came out to be, you get to maintain your fertility even for those. You know, some patients are going straight from issues of having fertility. I cannot conceive. I'm going to OB. I'm going to family doctors. And they have, of course, they have amazing tools up their sleeves too. And they're now working. And one of them is to jump straight to a very expensive procedure where you're doing tube pregnancies and all. Those are very expensive procedures. Well, we can bridge the gap in there too. A lot of times the tubes which are connecting the uterus and the ovaries are the ones which are the main problem. So they're not having the lumens being open so the egg can transfer there. Instead of going straight to a very expensive procedure, you can just come to us, and we have procedures where we can, without cutting you open, doing anything like that, go in and open the tubes with our small tiny catheters and wires. And we have had multiple successes, and that procedure is actually covered by insurance, whereas the tube pregnancies and those other options are right now not covered by insurance. They're starting at $35,000 to $40,000 just to have a baby. So our goal now is, I have one of my students and resident, we're actively working on it, to go and engage all of these fertility clinics and all of these OB folks who may not know that we are offering that here at UTMB, covered by insurances. Before, of course, that's a solution. If this doesn't work, at least send them to us. Let's look at it. Let's see if we can solve that issue without $40,000 and take it from there.
That's awesome.
Yeah. So it's a lot of work that we have at a lot of different fronts, and very thankful.
So you're trying to get the public to know what you do, but you're also trying to get your colleagues in other departments to know what you do.
Absolutely.
Yeah.
It's like two fronts we're working on actively. It's a lot of work for sure, but we enjoy it.
Yeah.
Like, we enjoy going out and talking to our folks.
You're passionate about it.
Yeah.
That makes for a good teacher.
No, absolutely. We love it. So all of my team is like that. So that's another important point, is like, you have to have the team who's on the same page.
Yeah.
So I'm blessed in that regard.
Well, Dr. Saleem, thank you for being on the podcast, and we appreciate the work you're doing.
Absolutely.